Hello, everybody. We're going to wait for some more folks to join us, but very excited to have you with us. I don't know if I should say good morning, good afternoon, or good evening, because it depends on where you are in the world, but welcome nonetheless. We'll be starting in a couple minutes.
Thank you, Dr. Bruce, and I'd like to welcome our audience today. This is part 4 of the 4-part IAS-USA webinar series on pain and addiction. And today's webinar will be addressing mental illness as a contributing factor of pain and substance use in people with HIV. I'd like to welcome today's speaker, Dr. R. Douglas Bruce from Boston University School of Medicine and Boston Medical Center. Welcome, Dr. Bruce.
Thank you so much, and welcome to everyone who's joining today. We have a lot of slides today, so we're going to try and go through things in a timely fashion. So first of all, you'll see on the slide, this webinar is available for CME credit. This lists the various forms of credit that are available, and as the email suggests, or the slide suggests, these will be emailed to you after the webinar. IAS-USA would like to thank grant support for the webinar from the various individuals or corporations that you see on the slide. Because of the amount of information, we're not going to have a whole lot of questions today, so my apologies for that. We will have time, or poll questions, we will have time for questions and answers at the end. And for anything we're not available to address during the time, shoot me an email and we'll try and sort it out later. So our first question for today is, from which geographic region are you viewing the webinar today? So is that South, the West or Midwest, South or Southeast, Northeast US, Canada, Mexico, Central South America, Europe, Asia, Australia, Africa, or other? And our survey says 43% of people are from the Northeast of the US, 41% in the South, and then we have people from all over the world, including Canada, Central South America, and Africa. So welcome to everyone for today's topic. And our next poll question, please rate your level of experience in the medical management of HIV. Number 1, novice, 2, 3, 4, or 5 is an expert. All right. And a nice bell curve there. We've got 34% at number 3. So we're very excited that there's a group of individuals that span all the spectrums of medical management of HIV. And let's dive into it. We're going to have 2 pre-test questions, and then we're going to get into the meat of it here. So hepatitis C virus infects 170 million approximately, and HIV infects less than 40 million people globally. How prevalent is depression globally? 300,000, 3 million, 30 million, 300 million, 3 billion. Lots of threes. All right. And if you have no idea, you have a 20% chance of getting it right. And we find that's correct. Good. My hope was that the 170 and the 40 million would give people hints that depression absolutely is much more prevalent than HIV and hepatitis C combined. Our next pre-test question. A person with bipolar disorder is newly diagnosed with HIV. How long do you wait before initiating antiretroviral therapy? 0 months, right at the first visit, 2 to 4 weeks, approximately the next clinical visit, 3 months, 6 months, 12 months. All right, and the survey says, look at that. Most people were doing it in the first visit, right then and there, or in 2 to 4 weeks. And so absolutely, the theme of this question is that when someone is newly diagnosed with HIV, we want to provide HIV therapy as soon as possible. And while many things could be happening related to the mental illness of the individual that might prevent us from prescribing today, for example, active suicidality or something else like that, most of the time, when you have the patient in front of you and they're willing to take medication, that's the time to provide the patient with medication. All right. We've got some learning objectives, which you would have seen as you signed up for this course today. We want to set some expectations. And the first is that, as you would expect, we cannot in 1 hour explain everything about mental health. Our goal really today is to provide a general overview and some practical take-home actions that you can do in your practice tomorrow. And I think that's going to be one of the key things that we do today, learning some new skills. We're going to recap a little bit from the last webinar, just because it's an important foundation. And so, as you'll see, it's really important just to remember that depression and substance use are very prevalent among people with HIV. They're at an increased risk of developing depression, anxiety, neurocognitive disorders. And we know that someone with HIV is twice as likely to develop depression, and that uncontrolled depression can lead to poor outcomes. HIV.gov has some very nice resources, and I encourage everyone to take a look at that for more information. And we used to, years ago, have only 3 spheres in this Venn diagram. And now, as the world and our understanding has just gotten more complicated, we realize that there's so many things that overlap for our patients. It could be a substance use disorder, co-infections, HIV, Hep C. Now we have coronavirus. Could be social determinants of health, mental illness, or chronic illnesses of other kinds, diabetes, hypertension, end-stage liver disease. And our patients are the patients in the middle, and they're dealing with all of these multifactorial issues. And today we're going to talk about the mental illness piece, but particularly how it interacts with these other spheres. So it's important just to remember that when we talk about addiction, because this is, remember, mental health care among people with HIV who have substance use disorders. So remember that addiction is a state in which a person engages in a compulsive behavior. That behavior is reinforcing, and they've lost control in limiting the intake. We'll talk a little bit more about the second bullet in a minute, but something I want to emphasize is the third bullet. All substance users must be screened for underlying mental illness. And I think this is an important just thought process here of, if we don't do this, a failure to identify underlying mental illness means recovery will be almost impossible. And we'll talk more about this in a little bit. And I think it's important to realize that failing to screen for mental illness is like starting someone on HIV therapy and never asking if the patient also has hepatitis B or C. It's that fundamental to the care of the patient. Why do some people become addicted? Why do some people develop mental illness? Everything is on this continuum of biology and environment. And what that really means is that some people are going to be predisposed genetically to addiction or developmental illness. We know that bipolar disorder, for example, is a high genetic component. But we also know that there are environmental insults. There are things that just happen in the environment that bring about or activate the genes or cause the illness. Why do substance use and mental illness occur? Well, there's 3 leading possibilities. One is self-medication. Substance use begins as a means to alleviate symptoms. So this is the self-medication hypothesis. For example, trauma leads to the use of heroin to numb the pain. There's also causal effects. Substance use may actually increase the vulnerability to mental illness. So some drugs can cause psychosis, like a stimulant, synthetic cannabinoids, for example. Drugs can also make someone vulnerable to assault. So while under the influence of something, decision-making is impaired and sexual violence occurs. There can also be other common or correlated or overlapping things, such that the risk factors that give rise to mental illness and substance use may actually overlap neurobiologically. I think it's really important to remember this, and the reason that this slide is here, this is the scan of macaque brains, and the first one you see is you got these 2 individually housed. What's lighting up is dopamine receptors in the brain, and you see that the top monkey, when it gets housed, it becomes dominant. It's almost like it's getting a neurobiological high there. See the lighting up. It's not as stressed. The bottom one, the one that's subordinate, is more stressed out. And you see in the far right chart that the subordinate, which is the red line, is now increasing its cocaine use. The reason this is important is because we have to remember often when we see a patient, we're thinking that the substance use the patient is doing or their mental illness is somehow only internal to the person, right? There are external things happening in the life of the patient. It could be violence, it could be a social determinant of health, it could be like racial discrimination, it could be economic, it could be all kinds of things, a loss of housing. There are lots of things happening in the environment. And this is really important for us to take into consideration because as we'll talk about, simply giving someone a pill to try to make mental illness better isn't always the best solution. So when we think about this, this is a kind of ever-feeding loop cycle, right? HIV itself can precipitate mental illness. It can drive substance use. And substance use and mental illness, as we've already talked about, are correlated strongly. When we think of some general principles, we really want to identify the substance use and mental illness. And the next slide is going to show us some important screening questions. One of the things that's critical is to pause and work on a root cause analysis. Just because someone is depressed, just because someone has some different changes in behavior, doesn't mean that it's mental illness. It doesn't mean that it's a worsening substance use disorder. There could be something else going on. So, for example, HIV or an opportunistic infection. I mean, it's a board question in ID when people are talking about changes in personality, right? Frontal lobe disease, frontal lobe infections can cause people to have a personality change, and that personality change, right, is often ascribed to mental illness, but it really is a biologic, it's an infection, right? Or it could be a tumor or something else. Metabolic things like a thyroid, hypothyroidism doesn't get better with an SSRI, right? So it's always important that before we jump on the bandwagon of this person has clinical depression, they need an SSRI and SNRI, don't forget that there are metabolic issues that can happen, especially in our patients with HIV. It's also important to take a step back and think, is the drug use driving the mental illness? So for example, patients using lots of cocaine or methamphetamines, and when they do that, they become psychotic. Or is there more mental illness that's driving the substance use? So for example, the person had severe trauma and the person's using benzodiazepines or alcohol or heroin to numb that pain. Something we're going to talk about in more length later is the use of motivational interviewing to increase engagement and behavior change. Why is this important? This is important, and this is a huge theme today, because even if you know what's going on, the patient may or may not be as aware of the issues as you are. And one of the critical things you need to do is help the person along the stages of change. It's to empower the individual and help bring them along and be motivated to engage in behavior change. All right. And then we have to work collaboratively with the patient, right? So these are for you in your packet, some substance use screening questions, which have been validated, and the PHQ-2, which probably most, if not all, already use in screening for depression. We know that depression is very prevalent among people with HIV, and mentalhealth.gov has some great resources as well on depression and anxiety. These symptoms of depression, the reason that I've listed them here is that sometimes depression is presenting itself in a way in which we miss, right? So the third bullet from the bottom, feeling tired even after sleeping well, right? So make sure that in our conversation with patients that we really are have in the back of our minds is that person waking up too early or sleeping too much or feeling tired, not wanting to engage in activities, right? So more aches and pains, more somatic pains. Could this person be depressed? We need to think more and more about depression in our differential. I alluded to this earlier, but it's really important for us to remember that when we do find a patient with depression, having screened in with an evidence-based screening measure like the PHQ-9, before we reflexively think, an SSRI will solve this, let me move on, is the patient facing a social issue? Is there homelessness? Do they need supportive housing? Does the patient have other symptoms? This is particularly important, of hyperactivity or possible mania. And that could, if an SSRI is given, lead to the precipitation of mania. So things to be thinking about, things to look out for. It's really important to remember that for many people with mental illness, the problem is bigger than what a pill can solve. right? And so this is why it's really important for us to focus on motivation to change, because we have to motivate patients to even take the medication. Just because you prescribe it doesn't make people take it. But also it's going to be important to help motivate people to go to therapy and address some of the root causes. I've included 2 studies from Africa, and the reason that I did this is important to understand, and that is that in whatever resource-limited environment that we find ourselves, there are measurement-based care systems that can be created. This is a very clever study that was done in Tanzania, and it was a nurse-led antidepressant med-management system. People were screened with the PHQ-9. If they had a score greater than 9, they were started on an antidepressant, and they were followed up because the PHQ-9 is validated for repeat measure. So they followed the patients up, and they kept titrating the antidepressant based on the PHQ-9. If it was less than 5, they don't change it. If it's greater, then they would go up in the dose. Right? Something similar was done in Cameroon. This was published in 2014. And again, it's the same kind of do a screen, get concrete data, initiate a treatment, follow up, do the screen again, where's the data? I bring this up because it's just really important to, when we think about in primary care, when we think about trying to do yet another thing, we often miss the opportunity of other staff members on our team to be strongly engaged in screening for depression and even helping to monitor the treatment of that depression. All right. I've got just a couple pieces here on anxiety, because anxiety is really important. We're going to talk more about anxiety later. But really, it's important to remember that people with HIV also have high rates of anxiety. Anxiety is very common in our individuals that use substances. And oftentimes, if a patient is asked, do you have depression and anxiety, they say absolutely both, right? Anxiety, really importantly, anxiety is often a fear of a future danger that's unrealized. And that danger could be real, right? There's a warrant out for my arrest. I'm anxious. I don't want to go to jail. Or it could be perceived. I just think this person's going to be unkind to me, hurt me. I might lose housing, right? Some anxiety disorders are rooted in the past experience, for example, trauma. And one of the things that we have to talk about here is that often that fear of that trauma recurring in the future is paralyzing in the present. And again, this is why motivation and helping patients be motivated to therapy becomes really, really important. This is the GAD-7, which is a structured instrument that you could use in your practice, to try and get some quantitative data looking at anxiety in your patients. When we think just very basically, we're going to have someone who's using a substance with a psychiatric condition, and the person also has HIV. And you got to think about starting somewhere. Now, these are not timelines relative to, okay, well, this week we do illicit drug use, next week psychiatry, and then 3 weeks from now we do HIV. What we're simply saying is we got to pick a place to start. And often where we're starting is the substance use and the psychiatric. And which one you're doing first is often trying to figure out which one is really driving things. Is it cocaine? Again, back to the earlier example, is cocaine driving the psychosis and the psychosis is causing problems? Well, maybe we need to see if we can get the patient admitted to an inpatient program, reduce access to cocaine, symptomatically treat the psychosis, start antiretroviral therapy. Or maybe it's trauma, right? And the patient's got this horrible PTSD and is using something like a heroin in order to numb the person's pain, right? So maybe we need to actually address some of the underlying psychiatric issues, because that's what's driving drug use, right? Maybe we're doing it simultaneously. We're going to get the person started on methadone maintenance. We're going to get them enrolled in seeking safety for trauma. Okay. It's really important to remember that none of these things are binary, right? So it may be that we're starting a person on a medication like methadone or buprenorphine, and they're going to stop using heroin. But it may be that the person is continuing to use, and so needle exchange, harm reduction is really important. And that's true in drug use. It's true in this example in trauma. The person could be denying trauma. So how do we be supportive? They may see trauma as impacting their lives. And again, it really is making sure that we understand that the patient that we're looking at, that we're working with, is not this kind of binary that switches on or off. You're all in or you're all out. Everyone, all of us are on this continuum of intervention and change, and it becomes really important to recognize where people are so we can engage them as they are. It's really key not to give up. I've lost count of the number of people that I had thought, there's just no way this person will change. And yet they've proved me wrong time and again. Don't give up. You never know when someone's going to want to change or be able to change. And that's why we need to help motivate our patients to change. So it's really important for us to start thinking about how people change. Now, normally we think that people change by discomfort, right? If they've hit rock bottom, if they're miserable, if, in the last quote there, when she feels bad enough about the trauma, she'll come around and start therapy. That's pretty much not the way it works, right? If the fear of negative consequences changed behavior, then our patients would never violate parole. They would never go to prison, right? The negative discomfort, that change is motivated by discomfort, would fix these situations, but they don't. So something else is going on, right? And one of the key things is ambivalence. We're going to talk more about ambivalence, but people are ambivalent about change, right? And because they're ambivalent, which is thinking two ways about the same thing, right? I want to be sober, but I'm scared of being sober. I don't want to go through the work of being sober, or I don't want to have the nightmares from PTSD, but I'm afraid to go through the therapy about it because I'm going to have to talk about what happened. I'm going to have to relive that trauma. So people often are continuing in this behavior, not because they're stupid or bad people or unaware. Sometimes people are unaware, but often it's because they're ambivalent. They're seeing the goods and the bads, the pros and the cons. And that's what ambivalence is, feeling two ways about something. And that's what we need to change. We need to resolve ambivalence. And we're going to do that with motivational interviewing, right? So one of the really, I can't emphasize enough how important this is. Motivation for change can be fostered by an accepting, empowering, and safe atmosphere. Be very thoughtful about the cues in your workplace, in your clinical environment that can be off-putting to patients, right? So it could be everything from, are you sitting in a seat of power? Are you elevated up over the patient? Are you talking down at the patient? Are you using words the patient doesn't understand? Are you not fully listening to? Are you not making eye contact? Are you busy typing away in the electronic health record with your back to the patient? What is the environment that you're creating? Is it safe? Does the patient feel empowered to speak up? Because if the patient doesn't, right, the patient's not going to listen to you as you try to motivate the person for change. The patient's not even going to be honest when you're trying to find out if the person's depressed. When we think about change, we're really trying to actually work through a natural process. Okay, where there's no voodoo here. People change through a natural process. We're going to try and make that happen. Something that's really important to remember, and this goes with kind of the earlier pieces about wanting to make sure that we have an empowering environment, is the faith and hope effect. And I'm sorry, I don't know why the slides have decided to move on their own. But it's really important to make sure that our patients are motivated by knowing that there's hope. Depression, I'm really sorry that this keeps doing this. Depression studies are still these randomized controlled trials with a placebo. And the reason that they have a placebo is because it's critically important that individuals actually get better with placebo in depression studies, right? 30 to 40% of people. It's really important to remember that if someone believes the therapy isn't going to work, it won't work. And one of the things you have to do is you have to help the patient understand that it's going to work. And if you can't sell that, they're going to see right through you. If you don't believe it, they're not going to believe it. And you're wasting everyone's time. You got to believe therapy works, and it does work. And you got to help sell that. You got to help sell to the patient that this is worth the person's time, that there's something better on the other end of this. And if you don't, then it's going to fall apart. Brief interventions are really important. 1 or 2 sessions can yield huge change. And that's why we're going to be talking about motivational interviewing. A little bit can do a lot. And this is really important to remember. Motivation is influenced by how you talk, how you speak, right? It's your style, right? It's really important to remember that one of the things that can happen is when the patient feels that you don't have motivation, that you aren't really sold into this, they're not going to believe it either. Again, faith and hope. Rolnick and others have really come up with these great things. These are some things that are in the slide deck that are just good things to remember, but giving advice, removing barriers. let's talk some more about some of the key things that we want to take home today. And that's really about this concept of ambivalence. People want to change and they don't want to change. Again, the patient with PTSD who wants to stop being anxious, but doesn't want to address the memories. And it's working with ambivalence that's key. These are the stages of change, and we're going to kind of break each one down. But the important thing to remember in this slide is that it's a circle, right? People go round and round in the stages of change. First of all, it's contemplation. People are, pre-contemplation, also known as denial. People are completely unaware. Depression's just the winter blues. Heroin's not a problem. These things don't impact my life. From pre-contemplation, people go to contemplation, right? People at this stage, they're considering whether or not they should change, right? They're comfortable with their coping. They're using drugs to medicate their minds, but they haven't done it yet. They haven't decided. Stage 3 is deciding. I'm going to do something. I don't know what to do, but I'm going to do something, right? And there could be a big time lag between that and this step, which is moving into action. People at this stage, they've begun a process of change. And what's important here is this last note. If heroin was the way to cope with PTSD previously, how does the person cope with it when the heroin's gone, right? If you're put on methadone or buprenorphine, what's your new coping mechanism? And that will be key for maintenance, right? How do we support and maintain the person in the stage of change? We need to always remember that relapse happens. Relapse can happen in depression or bipolar disorder because the person stops taking the medication. It can happen in drug use as well. Relapse happens. What's critical is that we don't shame the patient or make the patient feel that he or she is a failure, right? It's just part of the process, right? It's very important. It's just part of the recovery process. So when we think about our patients, right, we're going to have to think about how do we help our patients change, right? We start where the patient is, and we really have to make sure that we have a positive approach. As we talked about, positive approaches are critical as we move into motivational interviewing, right? And we're going to slow down. I know we've been kind of racing a little bit, but this is where the meat of things are. We've talked about the need to make change, but how do we help people make that change? And Blaise Pascal said, people are better persuaded by the reasons they themselves discovered than those that come into the minds of others. And motivational interviewing plays with this a lot. And there are 4 basic principles: express empathy, develop discrepancy, roll with resistance, and support a self-efficacy. All right, and this is going to be really, really important. Principle number 1, express empathy. All right, this is really, really important for us to take a moment and think about, right? Acceptance. How is the person feeling right now? All right. Skillful reflective listening is really fundamental to this. And we'll talk about reflective listening in a minute. But the patient's ambivalence is normal. And what we need to do is not label the person, but talk to them. So here we have an example. The woman says, I am so tired, but I can't even sleep. So I drink some wine, right? Now, what the individual here is doing is a person here, again, I'm sorry, my slides are possessed. One of the things that's really important is for
Dr. Bruce, so I do have
yes.
the slides available if you'd like me to share.
Yeah, I don't know why the slides are possessed and just keep doing this on their own, unless maybe I can. So I'm happy, Jose, for you to do them, or we can keep going with it as it is. And my apologies to everyone for the movement here. Wondering if it seems to be something with the sharing. So sorry again for that. So when we're expressing empathy, all right, the key here to remember is that the person's expressing something. The person's response is not judgmental. You drink wine to help you sleep. When I wake up, it's too late already. Yesterday, the boss fired me. You're concerned about not having a job, right? So the reflective listening that's happening is restating what the patient has said, right? I drink to sleep, you drink to sleep. Or you sleep, you have to drink in order to go to sleep. I lost my job. I'm worried about my job. That's expressing empathy, and it's done through reflective listening. It sounds really weird when you start doing it because you think that the parent person is going to think you're crazy for repeating the words back to them, right? But that is actually a manner in which the individual patient all right, so one of the things that's really important is developing discrepancy. So principle one is empathy, right? So if we go back to expressing empathy, it's really important that the patient make sure that all right, and my apologies, everyone. We're going to swap over the slides here so that mine are no longer possessed. So if we go back to the slide before, Jose, that'd be fantastic. So when we were expressing empathy, one of the things that was really important is to make sure that the patient feels heard, and helping the person feel heard. What they're doing is you're repeating back to the patient the things that you're hearing. Again, it feels really strange when you're doing that, but it's really actually critically important because you're using the words back, right? You're not processing it or judging it or labeling it, right? Because the person could have said, oh, you get drunk in order to sleep, or you pass out, or you black out. That starts labeling, that starts judging. The person's going to respond negatively to that. So when you're expressing empathy, what you're really doing is you're stating back to the person what they've heard. Again, that's important because the person needs to hear those words back. And what you're doing is you're developing rapport. You're building a bridge, right? And by building a bridge, by the patient really feeling that you are empathetically listening, you can then move to principle two and develop discrepancy. All right. And this is really, really important. And you got to be actively listening to develop discrepancy. You're going to start clarifying important goals for the client. You have to explore the consequences of these, or they could be potential consequences of the client's current behavior, right? So oftentimes I'm asked, well, what do you do when a patient says, I have no problems, my alcohol doesn't bother me, it doesn't bother with anyone, right? So that's where you start developing discrepancy. You'll say, well, gosh, I hear you saying that there really aren't any consequences for your drinking. But you told me earlier that your parole officer is violating your terms of your discharge and could remand you back to jail. That sounds like a consequence. Help me understand that. Again, it's trying to point out based on the things that the person has said, right? So let's go to the next slide. So here's an example. I enjoy having some drinks with my friends. That's all. Drinking helps me relax and I have fun. I think that I deserve that for a change. So drinking has some good things for you. Now tell me about some not so good things that you've experienced because of drinking. Well, as I said, I lost my job because of my drinking problem, and I often feel sick. Next slide. So that was an opportunity for the person to feel heard, for someone to distill down something that's going to be an important point to try and help motivate the change, right? You like alcohol, these are the positive things. Help me understand something negative. He could have said, you had mentioned this, but instead of referencing back to what she's already said, he gets her to restate it. And that's also very helpful to reinforce to the patient, yeah, there is something negative. Well, I lost my job. Principle three is rolling with resistance. I will tell you, I do this all the time. I do this with my staff. I do this with my family. I do this with the world, right? I do this with slides that move on their own. We roll with resistance. So one key thing is avoid arguing, right? It's really easy to want to argue with the patient. Can't you see you have an alcohol problem? Or don't you know that drinking alcohol will make your Hep C worse? Or don't you know that you're not going to get on a transplant list, right? It's easy to argue. If the patient starts to argue, you got to pump the brakes. Stop and find another way to try and engage the patient, right? Because what's happening is the person is going to become defensive. And if they're defensive, you're going to lose an opportunity to actually engage with the individual. You got to actually let the person, as we learned from Blaise Pascal, the person's got to come to this on their own, right? If simply telling people what to do worked, right? then all of our children would be doing whatever we told them to do, or our spouses or our jobs or whatever, right? People have to come to things on their own. They have to believe it for themselves. And when they do, they'll actualize it and do something. And so what we're doing in these 4 principles, right? First is expressing that empathy, saying back in reflective listening back to the person what we're hearing. We're trying to develop these areas of discrepancy. You think the world is great. Is it really that great? You think there are no consequences. Are there really no consequences? Right? You think life is great, but your family left you, you're homeless, you're on parole. Like, so it's developing those areas of discrepancy. But as you're developing discrepancy, people are going to get agitated, right? They're going to get frustrated. So be mindful. We want to avoid confrontation, right? There's a time for confrontation, but not in motivational interviewing, right? You might be confrontational if a patient is yelling at the nurse or the front desk or something and you need to confront negative behavior. But when you're motivating someone, confrontation makes someone defensive. You don't want the person to be defensive. When people are defensive, they're not changing, right? We're wanting to shift to perception. We're wanting to invite but not impose a new perspective, right? So that's when we'll see as an example, someone's going to kind of push back. We want to roll with it. We want to spin it around and try and bring in a new perspective to continue the conversation of change. All right, next slide. If we go back to our dialogue, I don't want to stop drinking. As I said, I do not have a drinking problem. I want to drink when I feel like it. But Anna, I think it's clear that drinking has caused you problems. Now, is that rolling with resistance? No, it's not. He's confronting her, right? You don't have the right to judge me. You don't understand me. Next slide. Right? Instead of, you have a drinking problem, right? There's been little bubbles here. Of course, he could be thinking that. But what he wants to roll with here, right? Instead of just giving up and saying, okay, yeah, you don't think you have a problem, fine. When you hit rock bottom, you'll change, right? Again, rock bottom's not the answer here, right? What's really important is, okay, person sounds like she doesn't want to change, doesn't want to stop drinking, right? So then how does he roll with this? Well, others may think you have a problem, but you don't, right? Now, some people may feel uncomfortable saying that because you're thinking, well, wait a minute, she definitely has a problem. How could I say, but you don't? But you'll see in her response, and I'll tell you, even though this is obviously staged for the slides, this really does happen in real life, right? Her response, that's right, my mother thinks that I have a problem, but she's wrong, right? So what you can see in this is she's reacting to the judgment that she's getting in her environment. It's clear that she's got people in her life who are telling her that she's maybe an alcoholic, a drunk, a bad person, all of these things. What she doesn't need from you is more negative commentary on her life, right? She's already getting all of that. She's already getting all of this negative stuff. What we need to do is we need to be thinking about, okay, how am I going to motivate for change? Well, if all that negativity was a motivation, she would have changed, but she hasn't changed. So all that negativity isn't the answer. What we need to do is motivate differently. And so his rolling with resistance, when she's saying, I don't feel like, I need to change, right? I want to drink when I want to. I don't have a drinking problem. He's able to keep the conversation going by saying, well, there are other people that think you have an alcohol problem, right? He doesn't have to say, well, I clearly think you're an alcoholic. You can say, well, there's other people who think you have a problem, but you don't. And I might say that, but I might say something like, others may think you have a problem, but I hear you telling me that you don't have a problem, right? So that either way, you're both presenting, there are people in the world that think you have a problem, but you're telling me that you don't have a problem, right? Next slide. Right. So principle 1, we've expressed empathy, right? We've been using reflective listening, using the words back to the patient that the patient is saying in order to help the patient really feel heard. As the person feels heard and feels engaged, you're able to continue the conversation and you're able to actually create an area of discrepancy. The discrepancy is to try and do what? To move the patient through ambivalence. Remember, ambivalence is thinking 2 ways about something, right? She's going to be thinking in her mind, I have a problem, I don't have a problem, right? I need to change, I don't need to change. And part of developing a discrepancy is to help tip the balance. We're wanting to tip the balance to change. And that change could be, as in this case, engaging in alcohol treatment. It could be starting antiretroviral therapy. It could be starting treatment for diabetes. It could be starting therapy for PTSD, right? as healthcare providers, all we're ever doing is trying to motivate people to change their behaviors. That could be taking a medication, you know, giving up donuts and sugar in your coffee, which would be a tragic thing, but, might be good for someone's health. When people react to that discrepancy development, they're going to get upset, right? Why are they going to get upset? Because they're trying to be self-protective. Remember, they're happy being ambivalent. We're the ones not happy with the ambivalence. We're wanting to tip the patient to change. So we roll with resistance. Again, rolling with resistance is not confrontational. We're not going to get into a fist fight with the patient. If confrontation and negativity were actually effective, people would be changing with all the criticism they got at home, right? Or at work or school or wherever, right? So rolling with resistance is continuing the conversation point out there, right? People think you have a problem. And then rolling with resistance is taking what she said. People think you have a drinking problem, but you're telling me that you don't have a problem, right? And we notice in her response, she actually shed some additional insight, which is of all the people in the world that she picks out, it's her mother. So that tells you right away, mom's a strong voice in what's going on. As we move into the fourth principle here, it's support self-efficacy, right? Why is it self-efficacy? Well, we have to believe in the ability of a person to change, and that's a critical motivator, right? So remember, if the patient has no belief in change, this goes back to the earlier conversation about faith and hope. If the patient has no hope of change, then it's really unlikely that they're going to change. If the healthcare provider has no hope they're going to change, you're not going to be able to sell the hope for change, and little likelihood of change there, right? We really have to help the patient be empowered. One of the other reasons individuals are feeling ambivalent is they feel that they cannot change. They don't have the resources to change. They don't have the skills. They don't have the ability, right? And few of us ever want to admit that we don't have the ability. Again, so it's easier just to be ambivalent. I'm not sure if I want to try to get sober. Why? Well, I don't want to face the possibility that maybe I can't actually change, right? So it's ultimately the client is responsible for choosing and carrying out change. This is the other critical reason that we have to support self-efficacy. We're not changing, the patient's changing, right? And so we have to help the patient believe that he or she is empowered to change, that they're able to actually go out and be a different person. That's what we're talking about in behavior change, to be a different person. And there's hope in the range of alternative approaches available, right? So it's not as though we are selling the patient lifelong sobriety on the day of the visit, or you will never feel depressed again, or there will be no more anxiety. What we're trying to do is move a person from, in this case, pre-contemplation, believing there's no issue, to contemplation, being willing to admit that there may be actually an issue that they need to work on. So we've been looking at these principles from pre-contemplation to contemplation, but these same principles are used to move someone from contemplation, right, to determination, to action, to keep them in maintenance. And if relapse happens, to help address the relapse and get people back to sobriety or to engagement in treatment or therapy or whatever it may be. Next slide. So here's an example of supporting self-efficacy. I'm wondering if you can help me. I've failed so many times. And I don't think you have failed. Right? This is really important, right? Because has she failed? Yeah, on one superficial sense, yeah, she's failed. She just says, I failed. If failure means lifelong sobriety, right, or lifelong behavior change, then everyone's failed, right? None of us are perfect. So we're not focusing on that. What he's focusing on is what? I don't think you failed. Why? Because you are still here, hoping things can be better, right? So he's not being dismissive. No, it's okay. I'm your cheerleader. Rah, rah, rah. It's, wait, I'm thinking about failure. I'm thinking about change differently, right? And I think we're actually thinking about it the same way. You haven't failed. Why haven't you failed? Well, because failure would really be giving up. You haven't given up. You're here, and being here means something. As long as you're willing to stay in the process, I will support you. Patients need to hear that, right? They're not going to be hearing that at home, right? with depression or PTSD, other things going on, they're not going to hear, oh, I feel really supported in my environment. That's not what they're hearing. I will support you. That's really important for them to hear their provider say. You've been successful before and you will be again. It's always important, especially when we're thinking about relapse and things have happened. When someone relapses or they get depressed, they stop their medication, they will often feel as though the past is erased, right? They feel as though every good thing that they've ever done is now gone. Oh, I was sober for, 2 years, and then I stopped uh, drinking, right? I was really great for those 2 years, and then I relapsed, and then that's all gone away. Or I was really doing well taking my mental health medications, and then I stopped. It all went away. We have to help people understand that there are benefits even when there's a relapse, right? So it's always important. The key things here, right? You haven't failed, you're here. I'm going to support you, and you've had success before. Again, this is all really trying to help the patient feel I can do it. I can do it, and I want to do it, right? Again, why? We're on this ambivalence piece. We're trying to tip her from, I'm going to stay in a position of not doing anything, to moving forward in a process of change towards being a different person. And it's really critical that we support that self-efficacy, again, because she is the one who is changing, right? Our job is to empower her and provide the tools so that she can be successful. Next slide. The ORs are some really important skills. When you can do this again with family, friends, and coworkers, but you can also do it with your patients. The OR skills really help when you're interviewing someone to help someone move through the process of change, right? So an open-ended question, right? If we just ask yes, no questions, we're not ever going to get the person to really come forward with some things. People really hate silence. Really do. Right? Everybody hates silence. And you'll see this. There's the awkward pause, right? Where people don't know what to say. It's awkward because we don't like the silence. And so what often happens in medical encounters, right, is the provider, also not liking the awkward silence, will take the person's pause when having asked an open-ended question as maybe the person doesn't feel comfortable saying anything, right? Give it a good 60 seconds, right? Don't just jump in after, if the person doesn't respond after 2 seconds. Have that open-ended question hang in the air. And you'll be surprised at what people will fill that with, what they'll come up with, and how they'll share, right? Also, when you're pausing, you're telling the patient, right? Not overtly, right? But by your behavior, you're telling the patient, I'm going to stop what I'm doing and listen to you. You are that valuable. That's really important. When people feel valued, they want to listen to what you have to say. They want to engage with you in treatment. They want to engage with you in behavior change. Affirmation is critically important. When I was working in an integrated addiction mental health clinic in New Haven, Connecticut, I would always tell the staff that life is really, really hard. And it's hard for all of us, and it's really, really hard for our patients. Our patients need affirmation. They need daily little positive things. And that could be as simple as, hey, you've got great sneakers, man. Or, hey, where'd you get that coat this winter? Or, like, oh man, that looks really snazzy. Or anything, right? As you get to know your patients, talking about family, talking about the things that are important to them and affirming them, right? I always tell the clinicians and providers, tell your patients that you're excited to see them today, right? For people with HIV, people who are substance users, people with mental illness, there are not a lot of people saying, hey, Johnny, I'm so glad to see you today. It's so exciting that you're in clinic today, right? People need affirmation. And if you're providing affirmation, what's going to happen? The person wants to spend more time with you. They're going to want to come back to clinic. They're going to want to listen to you, right? I mean, you can't underestimate the value of this, right? I spent a lot of time trying to help my patients feel very comfortable and really cared for and loved. And as a result, I've got patients saying that I was their doctor back in the 90s when I was a medical student in a different state, right? But for them, it's just Bruce has always been around. Like he's just always been there for me, even when I'm not always physically there, but they feel affirmed. We've been talking about reflective listening. Again, it's really important. You're saying back to the individual the things that you're hearing. It's really, really important because as you effectively are quoting back to the person what you're hearing, that individual really does feel heard. They know that you're actually listening to them and they're hearing these words back, right? And they're not going to feel judged unless you start processing it, right? Unless you start labeling it and saying, oh, you're a drunk, or you're a this, or you're a that, right? That's not what we want to do, right? That's not the goal. Reflective listening, saying back. One of the things that's really important is summarizing. And I've been doing this throughout our conversation today. I've been summarizing, right? I've been going back to say, and principle one is express empathy, and the next we go, we're going to develop discrepancy, right? And then we're going to roll with resistance, and then we're going to move into support self-efficacy. I've been summarizing because summarizing is really important, both to help make sure that the individual gets the key components as you're talking about behavior change, but it's also really important because summarizing is a way to restate what you're hearing, and it also is an opportunity to offer clarification, right? So I can say to the patient, I heard you say that you're struggling with your alcohol, or I heard you say that you're drinking yourself to sleep, and you're doing that because you're having nightmares. Well, wow, that's really that's really scary. I'm so sorry that you're having to do that. Again, affirmation, expressing empathy. I'm so sorry that you're having to do that. Would you be interested in talking with someone today, maybe one of our really skilled clinicians, right, who can help you, again, talking to the person about empowerment, can help you start thinking about ways that you don't have to suffer with these nightmares and maybe don't have to drink that alcohol to make the nightmares go away, right? So again, summarizing gives an opportunity to restate back, to highlight the things that are really important, and then build upon that, either building with clarification questions, building with moving towards, let's do something actionable today. Next slide, please. So there's some things that we've talked about that we need to avoid, right? Confrontation, you're an alcoholic, you're a bad person. Closed questions, right? How you ask a question will influence the answer. So we're not going to say, you want to stop drinking, right? Or of course you want to get into therapy for your trauma, right? Again, that's a judgmental question. It's confronting, and it's a closed question. Right? We're going to want to avoid some of the clinician traps that we've talked about, and we'll talk about some more. And we want to avoid any roadblocks to that reflective listening. One major roadblock is going to be judging, right, and labeling, right? It's going to be not wanting to say back what we're hearing, but wanting to add commentary to what we hear being said. And commentary is where we get into trouble. Next slide. So what are some of the traps, right? So the question, answer, the yes, no, confrontation, we've talked about denial. The expert trap, I think, healthcare providers are often famous for this. Well, you did the PHQ-9. Many patients aren't going to know what that is, right? You filled out some questions, you got depression, you need to take the pill. I'm the expert, right? Labeling, we like to label things, right? Oh, you have clear signs of major depressive disorder, or I think that you probably meet criteria for post-traumatic stress disorder, right? We can feel comfortable, and maybe we're going to chart in the medical record later MDD or PTSD or something else, right? But the labeling is not going to have the patient feel heard, right? The labeling is going to make the person feel that you're just categorizing them, you're dumping them in a bucket with a bunch of other people that aren't them, right? Don't run into that labeling. That can be a big trap. The premature focus trap, right? We all gravitate towards our favorite diagnoses. I remember the patient that I saw once who was diagnosed with bipolar disorder, and I was talking to her, and what was clear is that she'd gone to a mental health institution that really likes bipolar disorder as one of their favorite diagnoses. And when we teased out, well, what is really going on, we found out that she drinks a bunch of alcohol, smokes a bunch of crack. And when she's feeling really depressed, she's drunk. And when she's feeling really manic, she's smoking crack. And so when we talked to her about, well, so when you're not on these drugs, the last time you were hospitalized, were you having the racing thoughts? Were you staying up all night? No. That only happens when I'm smoking crack. We're really depressed and da da. Oh no, I just have a fifth of vodka. I'm like that. Again, prematurely focusing, going to the diagnoses that we think that are our favorites, and they may be our own subconscious biases, right? This is something where we have to be very thoughtful about. Are there certain people groups? Do we only think the homeless have a certain diagnosis, or other groups of individuals? Don't just run into something diagnostic. Again, motivational interviewing is so much about listening to what the patient is telling you and helping to motivate them to engage in treatment of some kind. It may be that it takes a while to figure out what are all of the various things that are at play in the patient's behavior and why they're changing or not changing. Motivational interviewing is just trying to help that patient actually move forward and change. And blaming is really easy, and it's easy for the patient to want to blame, and it's very easy for the provider to do it, to blame the patient, to blame their childhood, to blame someone else. Blaming doesn't help people change, right? Because when we blame, we often don't feel empowered to change. Blaming, we blame because we're a victim. And when people have a victim mentality, they often don't feel empowered to change. Stay away from blaming. We want our patients to feel empowered to change, to be different people. Next slide. So some of these are some of the roadblocks to reflective listening. So obviously, if we're ordering or directing or commanding, again, warning or threatening, that's the confrontation. Giving advice, right? We are not life coaches, right? So let's not run to provide a solution. Part of what's happening in motivational interviewing is we're just saying back what we're hearing, and the reflective listening is getting the patient to come to the conclusion on their own. When you tell them what you think, that's not helping them get to the conclusion on their own. It's antithetical to motivational interviewing, right? We're not trying to persuade people with logic, arguing, lecturing, right? We don't need to put up PET scans and all kinds of data on recidivism and why, the data here with methadone, buprenorphine, or this is the probability that you'll get better with an SSRI. These are not the things our patients need, right? Again, it's about the person coming to the conclusion himself or herself. Moralizing has really absolutely no place in a conversation about mental health or substance use disorders. Neither does judging, criticizing, disagreeing, blaming. Next slide. On the flip side, right, one of the things that we could do is we could just get super excited and start agreeing with everything, right? Oh yeah, it's, I totally understand that you need to drink to go to sleep because of the nightmares. I have nightmares too. And, sometimes I have a little nip at night. Agreeing is not getting where we need to do, right? Because if we're just agreeing, approving, and praising of the current behavior, why does the person need to change? Again, shaming and ridiculing, labeling are all roadblocks to reflective listening. We've talked several times about avoiding interpretation or analysis. I think it's important, there's a fine line between expressing empathy and reassuring, sympathizing, or consoling. Some of what's happening with reassuring, sympathizing, and consoling is putting yourself in the life of that patient or in countertransference, reliving your own experiences or your own issues related to the person. Those are big traps. Avoid that. If you're struggling because your patient reminds you of your daughter, your niece, your uncle, your whoever, you may not be the right person to be taking care of them at this time, right? You need to be able to distance yourself clinically. Questioning and probing can be real big roadblocks to reflective listening, because reflective listening is saying back to the patient, it's not, so tell me about the trauma that happened to you. Could you describe it in detail? I'm taking notes, right? That is not good. When people when they go through the trauma again, they relive trauma. It's the same reason that when someone memorizes a telephone number, you say it back to yourself over and over and over again. As someone with trauma says it over and over again, the trauma is more and more imprinted. It's more and more real. That's not helpful, right? Trauma therapists should help people address their trauma, not primary care motivational interviewing. Our goal is just to motivate the person to engage in that therapy, right? I love humor. I love to joke around all the time. Um, Often if, someone's making me uncomfortable, I might change the subject, but that's not going to be helpful in reflective listening, right? What we want to do is not make light of the situation with a joke. We certainly don't want to change the subject. We're trying to help the person change behavior. Next slide. Some of the things you should definitely ask yourself when you're in conversation with a client, again, like, what am I doing? Where are we going? Who's deciding? What am I saying? Why am I saying it? Am I really actively listening? And the last bullet there, are we dancing or wrestling? Motivational interviewing is often thought of as dancing because you're working back and forth with the patient in a partnership and reflecting back to the person. And it has to be this back and forth. Wrestling is that confrontation. It's always really important. Are you actively listening? We don't spend enough time really listening to what our patients are saying, and that's super important. Next slide. So when we think about the care of people with HIV, mental health, and substance use disorders, it's obviously very complex. We have raced through a marathon of information, and we have tried to talk about both the context, depression, anxiety, they're prevalent. They're interrelated with substance use disorders and HIV. We need to screen. We need to help create a positive, empathetic environment for our patients so that they feel empowered to change. And then we need to be empowered ourselves to help our patients walk through change. Now, many of you may be listening to this thinking, well, that's all well and good, but there's no way I can do any of that in my practice. And I will tell you that you absolutely can. You absolutely can. Starting this afternoon or tomorrow, you can start to listen to your patients. You can start to, whether it was a PHQ-9 or whatever data you have, engage with the patient. So you told a medical assistant that you're feeling down, depressed, or hopeless. What's going on? Can you help me understand more about why you told the medical assistant that, right? So again, it's being empathetic. It's trying to open up the conversation. You can do that. You may say you don't have the time. Well, I'll tell you that as a patient feels heard, as the person engages in treatment, it reaps dividends, especially as you're thinking about accountable care organizations and new ways for value-based care. People are paying for results. People, healthcare organizations, the government wants to see people get better. Our job is to help them get better. And to get better, we need to help people change. People who use drugs, people with mental illness, they're going to participate in the care services when they're organized around their needs. And people can really be successful, right? You really can treat people with bipolar disorder, depression, substance use, and you can help see them get cured, right? I took care of a bipolar patient, and we had to give him the old interferon ribavirin way back in the day to treat his hep C, and he got cured from his hep C, even amidst all of the other chaos that was ensuing with his bipolar disorder and his addiction. People can be organized people can be successful if we organize the services around their needs. And one thing that we all need more and more of is innovative ways to bring treatment to people who use drugs. And that's a big public health concern. And as we all go out from here, as we've been empowered to think about ways in which we can help our patients change, remember that it's not just change in addiction or change in mental health or change to help people take their antiretroviral therapy. Behavior change is what we're in the business of when we're doing healthcare. And we want to make sure that, and I encourage you to incorporate these principles of behavior change in all the work that you do and all the patients that you talk to. Again, whether it's helping to take metformin, whether it's for diabetes or to start insulin, whatever it may be, motivational interviewing and behavior change can be both empowering to you and to your patient and can bring about great things for everyone. All right, next slide. Thank you all. We're going to do our 2 post-test questions, and then we're going to have some Q&A. So I'm going to bet most people are going to get this right, since most people got it right the first go round. Hepatitis C infects 170 million. HIV less than 40 million. How prevalent is depression? We have A, B, C, D, or E. And the survey says, bingo, 300 million. Fantastic. And our next question A person with bipolar disorder is newly diagnosed with HIV. How long do you wait before initiating antiretroviral therapy? Right at the first visit, the next visit, 3 months, 6 months, 12 months. All right. Fantastic, 93%. Yep, right at the beginning. Again, the focus of this, looks like people voted the exact same way both times. Again, the focus of this was that we want to engage patients. We don't want the diagnosis of bipolar disorder to be in any way a barrier to starting HIV therapy, right? We start patients when they're ready to start. All right. And our next slide is time for Q&A. Thank you all. Apologies again for my audio-visual issues during the middle. And thanks to everyone for listening. Look forward to the question and answer. So if you want to unmute and ask a question, feel free to do that. You can also submit questions as well in the Q&A box. So one of the questions that comes through is asking for my contact information. So, and I apologize again, there was a little blitzkrieg there going through. So you can reach me at RDBRUCE, RD Bruce, no punctuation, at bu.edu. Another question is, how do you de-escalate patients in crisis when they want something from you that you cannot give? For example, if they are combative because they think you should prescribe or dispense a therapy you do not think is best for their health. So de-escalation is really, really an important skill. And like with reflective listening, we don't want to get combative. We don't want to get confrontational, because what happens is that things escalate. So some of it's going to depend on where the person is and what's going on, right? So if the person's yelling at the front desk or whatever, I might take the person aside into a room. I might have to say to the patient, one of the things that I've also learned is not to take personally when people are angry or upset or even yelling. So one of the things I will do is, in that situation, right, the behavior we're trying to change is maybe an angry outburst. So I'll do some ground rule setting, and I may say something like, Mr. Smith, I am so sorry that you're very upset, but just as you wouldn't want to disrespect, me to disrespect you by yelling at you, you're yelling at me. We can't have a productive conversation if you're going to yell at me, right? And I've been surprised actually about the number of times that people calm down and say, yeah, like I'm really sorry. I'm just really upset. And oftentimes there's something else going on. It could be that they really think that they need a medication because of some other issue, right? It's the only thing they think helps. There may be something else going on, and that's actually where the conversation is. I've also had conversations with people where it's like, look, I can't give this to you, or that sounds great, but I've had patients say, well, I need methadone for my back pain. Well, I can't give you a bunch of methadone for, once daily for opiate dependence, right? That's against the law. So there are all kinds of ways to appeal to try, again, focusing. Sometimes you have to say, we can't have a conversation today. If you're going to be yelling at me like this, you need to either go away and cool off. We've had to, call the police or have security escort people out before. But usually just allowing the person to kind of vent a little bit, not reacting and escalating it by yelling back at them, but talking to them calmly, and just, this is assuming the person is not intoxicated on crack or something else that's going to be activating. But oftentimes the person is going to calm down. But again, it's really important for staff to know what's going on, that you're having this conversation, for security or police to be aware, depending on the kind of patient and what's going on. Another question coming in. What if the supports, for example, housing, family, and search are needed for patients' recovery are not available? What can we still do to instill motivation for change? This is a great question. So one of the most powerful aspects of motivational interviewing is not that we always have the solutions, right? And so part of it may be helping to understand that the person's main concern is housing or something else like that. And so it may be that, I can't solve your housing problem today. I'm so sorry that this is what's going on. I hear you saying to me that, you're having to drink a fifth of vodka to sleep on a bench at night because you otherwise can't sleep. It's too noisy, or you're scared for your safety, right? It may be is there someone in your family? Is there somewhere place that you can stay that's safe? Maybe we can, get admitted to a hospital or get admitted to a housing, site or something like a rehab or something, or a detox even, to try and get someone off the street. So there may be some temporary fix to try and help get the ball rolling. But again, the key thing for motivational interviewing is you don't actually have to have all the solutions. What you're trying to do is help the patient think out loud about the problem and what they might need to do. Another question, can you talk about how you integrate Narcan harm reduction strategies into your primary care visits? For example, writing a prescription for Narcan, telling people to use together to keep themselves safe. Absolutely. One of the things that we'll talk about, because patients may often say, oh, I'm not using, or like, I don't need Narcan. And so one of the things that I'll often tell patients is, well, do you know anyone that uses drugs, right? All my patients know someone who's doing drugs, right? And so I'll say, well, look, maybe you don't need the Narcan for yourself, but maybe you need it for a loved one. And so it can be helpful for me to tell people about how, we've given Narcan to moms who aren't doing drugs because someone in their household is using drugs, and having Narcan has saved that person's life. And so from a policy perspective in our clinics, if you're involved in the prescribing of an opioid, right, it's required. You have to be involved in the prescribing of the antidote, right, of Narcan. So you should be offering that and prescribing that with people. For people who may not be prescribing opioids for whatever reason, we still encourage everyone to be thinking about, prescribing it. And you never know when you'll need it. I was walking down Mass Ave a couple of weeks ago, and there was a guy doing a line of heroin on the side of a building, right? So you never know where you're going to see it. Can you provide some motivational interviewing tips for engaging with the patient who is very interested in continuing chronic opiates or other controlled substances, perhaps for sleep, for example, right? So the way to think about that is almost exactly like the alcohol conversation that the gentleman has with the lady about her use of alcohol for sleep, right? And so it's going to be expressing that empathy. I hear that you're saying that you really need to take these opiates because they really help you sleep or they help you feel better. And so part of the discrepancy developing there would be to bring in the, opiates I'm not allowed to prescribe opiates for sleep because they're not indicated for sleep. So I'm really struggling as a healthcare provider to be prescribing something that I'm being told by the government, by kind of pick the organization that you want, but being told by X organization that I really shouldn't be prescribing it in this context. How can we work together to find a different treatment for your sleep? Because sleep's really important, and I really want to help you with your sleep. That's really important. Do you have some other ideas of things that we could do? Are there other things that you've tried? Would you like me to maybe look up some things or try and find something? Again, it's about the conversation. It's about expressing empathy. Sleep is important to you. I really hear that sleep's important. I want to help you with your sleep. I agree sleep's important. But then it's bringing in the discrepancy of, and then it's about, I'm in a conflict. I don't know. I want to help you. I can't help you with that. So work with me and help me find a way to help you that doesn't involve that. Again, complicated issue. But again, one of the most important things is trying to help. Another way to develop discrepancy might be, are there other negative things that the patient's engendering? Do they have low testosterone? Their bone mineral density is off, things that opioids can do. Are there other negative things that we can bring in to build that discrepancy that could be causing the issues? Thanks again to everyone who's took time this afternoon to talk to us about mental illness and opioids, and particularly motivational interviewing. I hope you found it helpful as you are going out into your practices, I really want to just applaud each and every one of you for the great work that you do to provide care to people who need not just knowledge and medical care, which you provide, but also the empathy and the real true caring that I know that you all bring to your patients. If you have any questions that I could be of help with that we weren't able to cover in today's webinar, feel free to email me, rdbruce@bu.edu. It's been my pleasure to talk with you this afternoon. I wish you all the best in all that you do. My thanks to IAS-USA for organizing these series of webinars. We truly hope that it's been of benefit to you, your practice, and your patients. Thank you very much.
Thank you, Dr. Bruce. Evaluations and information on how to claim continuing education credits will be available by 5 p.m. Pacific time tomorrow, and this will enable us enough time to review those that have pre-registered and have attended today's webinar. You may access the 2020 IAS-USA ARV guidelines in the following link. And we have one last upcoming webinar this December, and which will be next week. And the topic is HIV drug resistance. The recent on-demand webinars are available on our website as well, and which also includes the last 3 parts of the 4-part IAS-USA series on pain and addiction. And this webinar will also be available in about a day or 2 on demand on the website as well. This concludes today's webinar presentation. Thank you, Dr. Bruce.
Thank you.